Welcome, everybody, to another Grand Rounds on this lovely Thursday. Please grab a box lunch, sign in so we can keep track of how many lunches. I am very excited today to have one of our internal speakers, Dr. Kelly Arps. Kelly Arps is a cardiac electrophysiologist and clinical assistant professor of medicine at the University of Michigan, where she also serves as an associate program director for the Cardiac Electrophysiology Fellowship. She completed medical school at Emory University, residency training at the Johns Hopkins Hospital, and cardiology and cardiac electrophysiology fellowship at Duke University. She has strong clinical and academic interests in complex VT ablation, management of ventricular fibrillation, and cardiac sarcoidosis. She's going to be speaking to us today about VT ablation and structural heart disease, a 2025 perspective. Please join me in welcoming Dr. Kelly Arps. Yes. There we go.
Well, thank you very much. It's an absolute honor to be here and to be discussing a topic that I think is near and dear to or relevant to everyone in the room, which is this interplay between heart failure related to structural heart disease and ventricular arrhythmias. Now, this could potentially be a really big topic. And so I'm really going to focus in on a couple of key concepts and really focus on the modern landscape of evidence and what's still unknown. We're going to highlight this role of monomorphic VT in structural heart disease, specifically looking at the role of VT ablation as a treatment strategy for these patients and the clinical trial landscape. Through that, I'd like to identify some ongoing questions about the role of VT ablation in these populations. I want to highlight some modern strategies in both mapping and ablation technology that may help to make these outcomes different in the future. And then lastly, if we have some time, I'd like to spend 5 minutes highlighting a topic that's really near and dear to my heart, and that's the role of ablation in ventricular fibrillation as well as VT. So first of all, I want to highlight what the trials have said about the optimal timing for VT ablation and what benefit we might expect in referring our patients for VT ablation. As we all know, ICDs save lives. They protect our patients from sudden cardiac death. But we also know that receiving an ICD shock in our heart failure patients isn't benign. As this, now dated study shows, patients who have received particularly appropriate shocks are still at higher risk for adverse outcomes despite receiving those shocks out of sudden cardiac death. And we've all seen the morbidity that comes from hospitalizations after ICD shocks, as well as the mental health troubles that our patients suffer after receiving multiple ICD shocks. So the first trial to actually ask the question of whether we could reduce that shock burden in our patients with ischemic cardiomyopathy was the SMASH-VT trial shown here in New England Journal of Medicine in 2007. This study randomized patients with ischemic cardiomyopathy receiving a secondary prevention ICD to VT ablation or a control. I'll highlight here, this really didn't bring in antiarrhythmic drugs into the picture. They showed that catheter ablation in this population was able to improve the primary outcome of survival free from ICD shocks, but really didn't have an impact on overall survival in this population. And, importantly at this time, showing that it didn't have a positive or negative effect on the ventricular function across a year of follow-up in these patients. Since that time, we've had an additional trial that highlighted a similar population. This is the SMS trial, focused more on substrate modification with different outcomes. I'll point out that on this graph I'm about to show, the green is trials that did meet their primary endpoint for efficacy. The red is ones that did not. And then the next important trial in the landscape was VANISH-1. And this tested a different question. This was asking, okay, if we treat patients up front with antiarrhythmic drugs, and they still have ventricular arrhythmias, then which works better, escalating their antiarrhythmic drug therapy or treating with catheter ablation at that point? And they found that catheter ablation was superior to antiarrhythmic drug escalation. The next phase of trials then came back to this concept of earlier VT ablation, or VT ablation at the time of their first VT event or secondary prevention ICD. Berlin VT specifically compared early VT ablation versus deferred, which was after 3 ICD shocks. And PAUSE SCD was patients who had a positive EP study or prior VT receiving their ICD implant compared to essentially standard therapy. Some of these patients were on baseline antiarrhythmic drugs, some were treated with antiarrhythmic drugs, some weren't. This really was comparison to modern treatment strategy and showed catheter ablation had efficacy in that population. And then last, we came back to this concept of comparing more purely catheter ablation to antiarrhythmic drugs. Both Survive VT and Vanish 2, which was just published this year, compared patients with very early VT to starting an antiarrhythmic drug. They were in Vanish 2, they were starting on sotalol if they were a candidate, meaning they had good renal function. As the main criteria, or on amiodarone if they were not a sotalol candidate. And these trials also showed a benefit for their primary outcome. So what were these primary outcomes that we were looking at? In these, in SMASH VT, as I highlighted, the primary outcome was ICD therapy-free survival. In SMS, their primary outcome was time to first recurrence. As I point out, they didn't meet this outcome, but actually these patients who received ablation in this trial did have fewer ICD shocks, kind of fitting the theme that we're seeing here. Similarly, in Vanish 2, we saw a reduction in VT storm or ICD shocks with ablation as opposed to deferred or intensified antiarrhythmic drug therapy. In these trials over here, PAUSE-SCD, had a composite outcome. And these trials over here were some of the first to introduce this concept of maybe not only can we reduce ICD shocks or recurrent VT, but maybe we can also improve hospitalization. Maybe we can reduce the rate that these patients are getting hospitalized for heart failure as related to not having recurrent VT. PAUSE-SCD met its primary endpoint, but it was driven, as highlighted in bold here, by reduction in recurrent VT. Berlin VT did not meet its primary endpoint, which focused primarily on death and hospitalizations. And then our most recent trials, Vanish 2 and what showed a reduction in ICD shocks and slow VT, again, very much fitting this theme. Survive VT, interestingly, showed a specific reduction in treatment complications, meaning we avoided treatment complications related to antiarrhythmic drugs, which seemed better than the amount of complications related to VT ablation. And then Partita, very intriguingly, had a statistically significant lower rate of death in the catheter ablation arm compared to the standard of care arm. You know, this study, there's been a lot of discussion about it since, first of all, it was a very small patient population, and most of the deaths were non-cardiac deaths, really raising questions about the potential extrapolation of this result to claim a mortality benefit. I'd say the jury's still out on that one. And then most recently, the group in the preventive VT trial tried to move this concept even earlier. And you're asking if we could identify a sufficiently high-risk population to do VT ablation before they ever even have VT. And they chose patients who have a CTO and have a scar related to that CTO. And in that specific population, when they randomized them to catheter ablation versus simply receiving an ICD, they were similarly able to demonstrate a reduction in time to first appropriate ICD therapy. So taken together, I think we can really conclude from this that early VT ablation, specifically in individuals with ischemic cardiomyopathy, has been shown to be consistently effective for reducing recurrent VT and ICD shocks, which is an important outcome in our patient population. But what about non-ischemic cardiomyopathy? You know, that patient population is consistently growing in our practice. To date, only 2 of these trials have included non-ischemic cardiomyopathy in their cohorts, and there's been no trials that only looked at non-ischemic cardiomyopathy. I've already mentioned some of the discussion about the outcomes in Partita. PAUSE-SCD had about a third ischemic, a third non-ischemic, and a third ARVC populations performed mostly in Asia. And, interestingly, when you look at the subgroups, the groups who were the group that was ischemic did seem to have the best benefit from ablation, with the non-ischemics not seeing as much statistical benefit from ablation. It's hard to know what to do with the subgroup analysis, but suggesting that the jury's really still out in terms of trial benefit for non-ischemic cardiomyopathy VT ablation. And then, as we know, non-ischemic cardiomyopathy is a really big group with a really heterogeneous population. As this analysis from the multi-center registry, the International VT Center collaboration showed, this is slightly older data, but I think it still holds true, that depending on the substrate of non-ischemic cardiomyopathy, we could have really different outcomes, with sarcoidosis patients very classically being difficult to get good outcomes from ablation, and ARVC classically being patients who respond very well to ablation. Another interesting point about these trials is the role of amiodarone. There's been 3 studies where I want to highlight some components of this. The first was Vanish 1, where specifically, remember, we compared catheter ablation to antiarrhythmic drug escalation. And in that particular study, in a later subgroup analysis, they found that there really weren't able to demonstrate a benefit of VT ablation in patients who were naive to amiodarone at the time of randomization. That the real benefit was seen in patients who were already on amiodarone at the time of randomization and would have been escalated to an additional drug other than amiodarone. In VANISH-2, the follow-up to this study, they found that those patients who were eligible for sotalol, meaning they got sotalol as their first line, had the most benefit from ablation, whereas those patients not eligible for sotalol who got amiodarone as their first line drug didn't see as much benefit comparatively from ablation over amiodarone. And then lastly, I'll highlight Survive VT, where if we remember, the primary driver of their composite outcome was reduction in adverse events. That's reduction of adverse events related to antiarrhythmic drugs, many of which were on amiodarone. So I think we can summarize that amiodarone is pretty effective at treating VT, similar to catheter ablation, but it's got a risk of adverse events. And as we've seen in a lot of our patients, a lot of side effects as well. And so VT ablation really seems to be the most favorable in those who are either refractory to or intolerant of or not a candidate for amiodarone. So in summary, highlighting what I've already showed is that ICD shocks are the strongest indication for referring a patient for ablation. That failure of antiarrhythmic drug or unwillingness to take a drug, particularly amiodarone, pushes us more towards ablation. And that, we've got a very heterogeneous population for both ischemic and non-ischemic patients, so shared decision-making really remains key. So in summary here, we've got a lot of patients who have heart failure and ventricular arrhythmias. And we know that through some fantastic work in the heart failure community, we have 4 strong drugs for GDMT. Those are improving heart failure outcomes and subsequently improving cardiovascular mortality. In the ventricular arrhythmia landscape, we've reduced sudden death with ICD. We've reduced VT and ICD therapies with catheter ablation. But I think the jury's really still out on whether that translates to an improvement in heart failure outcomes and mortality directly. I'm going to make an argument. I think that's still possible. Here's another analysis from the International VT Ablation Center collaboration. And this, looked back at multiple, VT referral centers ablation outcomes. And they had shown that, VT ablation didn't appear to improve mortality the same way we see in the trials. But then they broke it down between patients who had recurrence of VT after ablation and patients who didn't. Now, obviously, this is also representing the baseline level of illness and comorbidities and heart failure status. But they showed, in a pretty obvious split that patients who didn't have a VT recurrence did do a lot better in terms of transplant-free survival compared to those who did have a recurrence, arguing that maybe if we could get a little bit better at success after VT ablation, we could start to see more of those beneficial effects. A later publication from the same group showed that this relationship remains true even in patients with NYHA class 4 heart failure. On this graph, we see the NYHA class 2 and 3 in green, the NYHA class 4 in blue, and see that in each of those groups, there seems to be a split with patients with no VT recurrence doing best and patients with early VT recurrence doing significantly worse. Even in a non-ischemic cardiomyopathy cohort, the same relationship holds true. This is a different multi-center analysis showing the exact same thing, that there's a relationship both with their baseline illness status represented in this study as left ventricular ejection fraction on the right-hand graph, and with recurrent VT, as shown by the orange bar over there on the left, that patients with early VT recurrence really did the worst. Let's break down VANISH-2, our most recent VT trial, just a little bit farther. Remember, this showed that VT ablation reduced recurrent VT, but didn't meet the secondary outcome of a mortality benefit. Even in this trial with, done at referral centers with pretty rigid protocols, there still was a 61% overall VT recurrence in the ablation arm. Not all these patients got ICD shocked, but overall 61% recurrence. So again, highlighting, maybe if we can get that recurrence rate lower, we may have better overall outcomes. Secondly, actually, a majority of the deaths weren't from VT, they were from heart failure. And even though this is a relatively modern trial, this still was in the era of evolving GDMT and GDMT activation. Only, very few of those patients were on SGLT2 inhibitors in particular. So maybe as we are really now in that modern era of GDMT, these patients, again, may have overall better outcomes from treating both their heart failure and their VT. Or, I'll posit that it's still possible that they just have too many competing risks for death. So while we can't say this yet, I think what I'll say is that potentially successful VT ablation might end up improving heart failure outcomes and mortality, and more to come. How do we get there? First, I think there's a role to refine our candidacy selection for VT ablation, really exposing patients to that risk of a procedure who might best benefit from it, optimizing our peri-procedural management, and I'll talk more about that later on. And then lastly, making progress both technical and on the physician side in VT ablation efficacy. Let's talk a little bit about electrical storm. This is a special population of patients. We know that those patients tend to have a stronger indication for ablation, particularly when refractory to antiarrhythmic drugs. I'll highlight mostly for the fellows in the room that there's a lot of things that can be done before we're considering catheter ablation to help optimize these patients' chances of leaving the hospital alive. We know that the end risk of being in electrical storm is hemodynamic collapse and associated end organ failure from lack of perfusion. So if our initial strategies of antiarrhythmic drugs and repeated cardioversions or defibrillations aren't doing the trick, that in patients with this high sympathetic drive of ongoing electrical storm, deep sedation can really be a stopgap to help quiet the storm, while we come up with a more long-lasting strategy. And if that doesn't work, that for patients who are really on the brink of falling off a cliff, that early consideration, at least of mechanical support, particularly ECMO, can really make a difference in the patient's outcomes. And now here, I'm not talking about the patient who has chronic advanced heart failure, lots of comorbidities. We know those patients don't do great on mechanicals after an ECMO run. But I'm talking about those patients who you were otherwise functionally well, may even have idiopathic ventricular arrhythmias. Their primary problem is an electrical one. And a lot of times we can bridge those patients well with mechanical support to get them to a rhythm control measure. So when should we bring those patients for catheter ablation? There's been a couple of recent studies. This is a study from another groups looking at the question of, okay, do the patients do better with very early referral catheter ablation or initial upfront medical therapy? And in their group, this is a retrospective study, the median time to their initial ablation was 6 days. A lot of these patients were already on antiarrhythmic drug therapy. And they found that early ablation was associated with lower VT recurrence and lower subsequent cardiovascular hospitalizations. One thing I'll point out here, I looked all through this when I was preparing this talk, and it's really hard to find out from this data how many of these patients ended up getting deferred ablations, after that initial resuscitation phase or after that initial hospitalization. I think that question could really help us understand better, how sick or not sick the patients who didn't get early ablation were at baseline in this cohort. But these are the data that we have here. Our group, in an effort led by Jackson Lang, asked a slightly different question that I think adds to this, to the prior study. And they asked the question of, if patients are able to stabilize on antiarrhythmic drugs, meaning we start them on antiarrhythmic drugs, the VT quiets down, then do we need to bring them for ablation right away, or should we bring them back in a more controlled setting to do so? And that we found retrospectively that those patients who did stabilize initially, that they had a much better outcome than those patients who got urgent ablation because they didn't stabilize on antiarrhythmic drugs, suggesting at least that this deferred ablation strategy is a reasonable strategy for the patients who quiet down. This was a median ablation time of 7 days in the urgent group versus nearly 3 months later in the deferred group. And they found that one of the biggest differences was actually major complications, that there was a major complication rate of 18% in the urgent group versus 4%, which is more in line with current trials and data in the deferred group. Both of these studies have relatively small sample sizes, but I think very interesting food for thought. Now, what about our patients? I mentioned earlier that it's a whole different story when our patients already have advanced heart failure and cardiogenic shock. I do think that this is a scenario what's truly definition of being between a rock and a hard place, where on one side, urgent advanced therapies, particularly urgent transplant in the setting of electrical storm, exposes our patient to risk of worse outcomes than patients who get transplanted in a more controlled setting. Often these patients might be on mechanical support. They've been bed bound. They're often on amiodarone, which has been shown to increase the risk of primary graft dysfunction. And so if that intervention can be delayed in any way that's preferable. On the flip side, as we've just discussed, urgent VT ablation, particularly in the throes of critical illness, can also increase the risk of adverse VT ablation outcomes, including end organ damage that could compromise transplant candidacy in the future. And so these are really, really difficult situations. This was, I think, one of the first studies to actually look at this group of patients. These are patients with advanced heart failure and electrical storm who went through ablation at the University of California, San Diego. And they found that overall, after getting an ablation, 23% of them were transplanted during that 1 year of follow-up, that their overall survival was 77%. And VT recurrence was similar to what we've seen in other similar populations. Most interestingly, they showed the same theme that we've been, seeing in a lot of studies, which was being able to get these patients without VT recurrence resulted in them having the best outcomes in follow-up. Oh, and I'll go back there, maybe. And that lastly, those patients who were the most sick, meaning a UNOS status 1 or 2 for electrical indications, were the ones that did, for the most part, end up needing transplant or unfortunately dying in that population, as opposed to those who were less sick at the onset. Okay, what about these patients who are candidates for LVAD? As we've all seen, the LVAD doesn't make the ventricular arrhythmias go away. Multiple groups have, published their analyses showing that ventricular arrhythmias are common after LVAD, and that ventricular arrhythmias, in particular, early electrical storm, has been associated specifically with increased mortality after LVAD implant. And multiple studies, including this one here, have shown that having prior ventricular arrhythmias is the strongest predictor of having post-LVAD ventricular arrhythmias. I think the more difficult question is, what do we do in this population? Particularly the patients who maybe aren't having VT right now, but had VT 6 months ago and now are being referred for an LVAD. This is the timeline showing the different ways in which we could consider VT ablation for these patients. We could consider doing an ablation prior to their LVAD implant. We could consider surgical ablation at the time of their LVAD implant, or we could say, let's see what happens if they have VT after their LVAD. Then we could treat them appropriately or bring them for ablation. In the pre-LVAD group, there's the risk that we're doing VT ablation in a very sick patient who may already be hemodynamically unstable. And we're talking about 2 runs of anesthesia, both for the VT ablation and for the LVAD implant. As alternatively, if we do surgical ablation, it makes it a technically more difficult ablation. We're dealing with a space we're not familiar with, adapting the mapping system for the operating room environment, adopting the EKG leads for the fact that the patient has a sternotomy. But it does allow direct visualization and mapping of the heart in a very controlled setting on cardiopulmonary bypass. That said, it's a longer run of cardiopulmonary bypass for the patient. And then lastly, if we do reactive ablation, there's always the chance that we miss our window. That if the patient has electrical storm in the very acute postoperative period, particularly if they have some right ventricular failure, that can make them sick enough to have adverse outcomes or not be a candidate for ablation. I'll also point out that in this group, we will have lost our option for epicardial access if needed, particularly in our non-ischemic patients. Thankfully, there's a multi-center trial that's going to try and help us answer this question. The pivotal trial is a multi-center trial that's enrolling right now, and they're randomizing patients who are LVAD candidates who have a history of prior VT to either a standard management or intraoperative ablation, and this would be with cryoablation during surgery. Their primary outcome is going to be recurrence of VT, and I'm very excited to see what the outcomes of this are. Now let's talk a little bit about mechanical support. So here's all the reasons that we worry about bringing our patients to VT ablation. They're already sick patients. They already have tenuous hemodynamics, and we make that worse by putting them under anesthesia or sedation, as well as by repeatedly putting them into VT in order to map the VT and understand where the circuit is. Well, if you look at these 2 different studies that show causes of early mortality after VT ablation, recurrent VT is the most common attributed cause, but the second most attributed cause is heart failure. And we can make the argument that a lot of these cases are at least somewhat related to worsening their hemodynamics at the time of VT ablation. And I'll point out that some of us in the room are familiar that we've learned that lesson the hard way with one of my own patients recently. This was a study that showed that specifically needing to use rescue mechanical circulatory support is associated with worse outcomes and specifically higher mortality than preemptively implementing mechanical support to support a VT ablation. The group at Penn a couple of years ago, or now 10 years ago, put together a series where they looked retrospectively at risk factors for acute hemodynamic decompensation and came up with this score here, which helps us risk stratify patients. And in applying this score, they found that when they did upfront hemodynamic support in those patients in the highest risk category, that they were able to improve mortality compared to a standard approach. I will point out that really the goal of this strategy was to improve mortality, improve hemodynamic stability, but that this here showing VT recurrence shows that it really didn't make the ablation any more effective. It just helped the patients to do well after the procedure. There's been many series now published on the long-term or intermediate-term outcomes of mechanical supported ablation in these patients with high risk. And, I'll be honest, I think the results have been mixed. We see, as we showed in the prior study, similar recurrence rates with versus without mechanical supports. We see that there's definitely a trend towards higher procedure-related complications with mechanical support, very often vascular access site complications, but also all the known other complications of mechanical support devices. And then lastly, we still have a group that's at risk of transplant, LVAD, and mortality, even despite such supports. I think there's some trends that are leading towards us potentially needing to use this strategy less. And that's the fact that we're moving away from this strategy of a targeted VT ablation that was first described a couple of decades ago, in which we, in this approach, our goal is really to identify the whole VT circuit in order to find that critical isthmus that the circuit is dependent on. So it requires keeping the patient in VT while we're doing our mapping, repeatedly putting the patient in VT. And it's been shown to, it was what introduced the concept of VT ablation, but we now have an even better understanding of what we're doing. And now we've moved more, particularly in these high-risk patients, into the concept of substrate modification, where we can do a map of the patient's heart and sinus rhythm or in a paced rhythm, and we can identify areas, we can very clearly delineate where their scar is and identify areas that are at highest risk of being arrhythmogenic. This often results, if you've ever looked at pictures of our maps, of us doing a lot of ablation all through their ischemic scar or their non-ischemic scar, but it does give us the ability to do less VT induction and less time spent in VT, which leads to less risk of hemodynamic decompensation. And I think anecdotally, at least, we as a field have seen fewer cases that we're using mechanical support for because of this substrate modification strategy. In an effort led by Mike Ganem, our group very recently published an analysis looking at this, where we looked at a series of patients who have a severely decreased left ventricular ejection fraction. I've highlighted this as a sick population, mean ejection fraction of 13, left ventricular and diastolic diameter greater than 7 centimeters, many of whom had storm or prior VT ablation, and found that in these patients who didn't get mechanical supports, with really careful pre-procedure evaluation, hospitalization, a substrate-based ablation using the image guidance that we love, the patients did have a low procedural complication rate, and none of them needed preventive or rescue mechanical supports. The average length of stay of 7 days, which I think is pretty good for a sick population, but still in follow-up over a year, 11% received an LVAD, 29% died, and 55% had VT recurrence, showing that we still have work to do. So how do we minimize these risks associated with catheter ablation? Well, I highlighted all of the problems that lead to hemodynamic decompensation. So first, I think there's always a role for really careful candidate selection. First of all, to make sure that the patient really we think they would benefit from VT ablation. And secondly, to make sure that they, that we understand their comorbidities, understand their hemodynamic status. There's a lot of work we can do collaborating with our anesthesia and lab teams to best manage the whole patient and not just the electrical portion of their heart during the procedure. And then lastly, as I keep highlighting, I think we're moving towards trying to limit the number of times we actually put the patient into VT during the ablation procedure. So what does that look like in practice? First of all, before the patient ever comes into the hospital or the lab, it's really well documenting what their current heart failure status is. understanding their current hemodynamic state with a right heart catheterization if necessary to understand their current filling pressures, cardiac output, pulmonary vascular resistance. I think it's become very important to us to try to understand what the patient's candidacy would be for advanced therapies if they were to have a decompensation during or immediately after the ablation, so we can make wise decisions about implementing things like mechanical support in those patients. And then lastly, bring the patient in for pre-admission. For the patients who come in for outpatient ablation, we may see them weeks before in the clinic, and we understand what they were like at the time, but this is a patient population that's changing quickly. And so having them come into the hospital a day or two before, make sure that they're appropriately volume optimized, allow them to wash out their antiarrhythmic drugs in a supervised setting, I think really helps to protect our patients. Secondly is three-dimensional imaging. We like both CT and MRI in a lot of our patients. They provide complementary information, including looking at the scar substrate, often the most important thing, understanding where we're going to be working, and then locating some of these other structures that can impact how we do our job and trying to avoid complications. This is the in-heart software where we send CT and MRI images to the group that runs this company in Bordeaux, who then post-process it to create these beautiful three-dimensional models that we see here. As you can see on the left, the structures from the individual studies have been highlighted and outlined in 3 dimensions to create that model where we can add or peel away layers as needed. We also implement this model directly into our mapping system, to understand what we're working with relation to these structures. Doctors Ganem and Bogan have been really instrumental in a lot of publications showing what can be done with 3-dimensional imaging for VT ablation, including the study on the left highlighting the fact that CT can actually help us predict where that VT isthmus is, just looking for areas of wall thinning between 2 areas of thicker myocardium. And on the right, by seeing where the location of these coronary veins, where we're often mapping to try to find epicardial substrate in patients with VTs originating near the mitral valve, and being able to visualize where that is directly related to the scar and the potential VT substrate. Lastly, I think there's always room to work very, very closely with our lab staff and our anesthesia team. Almost every single case, we use invasive arterial blood pressure monitoring. We ask our anesthesia team, when possible, to really minimize the amount of sedation. This is one that's really up in the air when it comes to the VT ablation field. I've spoken with ablationists in other centers, some of whom do every single case under general anesthesia just to have control of the patient's status, and others who really try to minimize the amount of sedation. So I'd say it's still a very individualized approach. If pressor support is needed, we know that adding that afterload for our heart failure patients can really make them a lot sicker either during or after the ablation. So I'm often communicating with the anesthesia team, asking them if they need vasopressor agents to consider using something with some inotropy to help support the patient's cardiac output. And then lastly, our patients all get a urinary catheter so that we can monitor ins and outs, understand both their fluid balance as well as just their perfusion via renal function, and give them intraprocedural diuretics if needed. Next, I want to highlight, I mentioned earlier that I think continued improvement in the way that we do our jobs could continue to improve outcomes after VT ablation. So I'm going to highlight a few current innovations as well as potential future innovations that may help us do that. First of all, I already mentioned this transition from targeted ablation to substrate modification. I mentioned that targeted ablation, there's a lot of sustained VT, and also in its purest form is very limited. It doesn't target all of the potential circuits within a scar. Whereas substrate modification is the complete other end of the spectrum. We often have very long ablation times, 1 or 2 hours total of just radiofrequency ablation. And it is a more probabilistic approach, which isn't very elegant or targeted. The two of them are really coming together now in this concept called functional substrate mapping. For any potential electrophysiologists in the room, you'll see this in the literature under a lot of different names, things like deceleration zones and waddles. They're all really getting at the same concept, which is that in sinus rhythm or during pacing, without putting the patient in VT, that we can not only identify where the scar is, but we can identify those zones where the electricity really slows going through the scar, and that's just a setup for ventricular tachycardia. And so there's been a lot of work where they essentially line these up with VT maps and show that these zones of slow conduction really do correlate with where the isthmus is in VT, suggesting to those of us in the future that we may just be able to use this and not necessarily have to put the patient into VT. In the far future, this may be done even outside the EP lab. There's multiple groups, including this one, using some form of AI or digital modeling technology to use just the three-dimensional imaging to suggest where the VT targets are. In this particular study, they use a concept called a digital twin, where they turn a 3D structure, in this case MRI, into a heart model, and then they ask it to simulate where the VT circuits are. They then simulate ablation, cutting off the first circuit that's identified, and then repeat the process, asking it to say, okay, now that you've cut off this circuit, where's the next VT circuit going to be? So certainly, has a lot of work before it's mainstream, but really promising for the future. Now, here's an image that looks really familiar to a lot of us. This is an MRI in a patient who has a non-ischemic cardiomyopathy. We see that mid-septal late gadolinium enhancement representing mid-septal scar. And we hate seeing this because that's right in the middle of the myocardial wall. It's really, really hard to map, and it's really, really hard to get ablation energy into that site. One of the recent innovations that helps us do better VT ablation for that population is the concept of mapping in the coronary venous septal perforators. So just like the arterial perforators, these venous perforators go deep into that ventricular septal wall. And we can't get an ablation catheter out there, but we can get a microcatheter out there. And you can see that over here in these images. This is the coronary sinus, and this is one of these septal perforators. And by identifying potentially the critical signals in that catheter, we then can line up our ablation catheter directly opposite wherever that site is to have a more targeted ablation in that region. And that's something that we're doing, right now, I think, to help us get better outcomes in particularly these non-ischemic patients. Here's an overview of other either currently available or pending ablation technologies, which again may be helpful, particularly for deeper mid-myocardial substrates. You may have, as you may be familiar, bipolar ablation is something we'll offer occasionally. Lower ionic uricant, which is half normal saline, is something we'll offer sometimes, as well as what's highlighted down here is chemical ablation, which is instilling ethanol into those septal perforators. A few more that I want to highlight in more detail. Just a couple of weeks ago at the VT Symposium, the initial results of a trial that we've enrolled in here using the Adagio cryoablation catheter showed it's ultra low cryoablation, so colder than what we've used previously for other arrhythmias, with the idea of creating direct cell destruction. We don't have the actual trial outcomes yet, but they said that with their initial ablation that they had high acute procedural success, that they had low complications, but we haven't looked at the arrhythmia recurrence outcomes yet. So more to come on this front. However, pulse field ablation, as you may have heard, we're using quite routinely for atrial fibrillation ablation now, and I think it has a lot of promise for use in VT ablation as well. It's all off-label in the ventricle right now, but there have been compassionate use cases and experimental cases published showing that using the pulsed field energy is able to create deeper lesions and can often bypass scar, helping us get to these deeper substrates, as well as the fact that a lot of these catheters are very large footprint, allowing us to do much larger lesions and reduce the ablation time. There's a lot of work for us to do to make sure we're not causing too much destruction with these, very powerful weapons. But I think it can make a big difference in the ablation landscape. And then lastly, there's been some fantastic basic and translational work looking at the interplay between the autonomic nervous system, arrhythmias, as well as heart failure. We've already seen the benefit some patients get from stellate ganglion block or sympathectomy for improving their outcomes in refractory arrhythmias. And I honestly think that that's just the tip of the iceberg, that with a much more nuanced understanding of this interplay, there will be much more targeted therapies and understanding of the right candidates for these therapies. Lastly, we do have a few minutes left, and so I want to talk about one other concept in ablation that I think is new and exciting, and that's VF ablation. So we've known for a long time, almost more than 20 years now, that for patients who have what we call idiopathic VF, meaning they're not acutely ill, they're not in cardiogenic shock, they just have VF, that it often is triggered by very reproducible PVCs. And that finding that PVC trigger and ablating it can reduce the rate of those patients having VF. That actually was shown then extended to multiple populations, patients with structurally normal hearts, the so-called idiopathic VF, Brugada syndrome, long QT syndrome, ischemics, and mitral valve prolapse. And, taken together, I think, those in our field would agree that if a patient is having recurrent episodes of VF that we've demonstrated on either telemetry or Holter monitoring or an ICD that's reproducibly triggered by the same PVC, and if we're seeing that PVC frequently enough that we can actually see it in the EP lab and map it, then it's reasonable to offer our patients PVC ablation in order to reduce their VF burden. Much more recently, Dr. Hasigari and the Bordeaux group did a really fascinating study looking not just at that PVC trigger, but also at the very beginning of VF. They used non-invasive body surface mapping to watch what happened in those first several beats after the PVC trigger. And they found that there often was a reproducible driver area that was different in different substrates, but very often involved the Purkinje system, essentially hypothesizing that what happens is, that a lot of our VF patients, again, not the ones who are acutely ill, not the ones in shock, but the ones who just keep having recurrent VF, that this may be related particularly to a diseased Purkinje system. They have a PVC that then has micro reentry within the Purkinje system that then degenerates into the chaotic electrical activity that we all think of as VF. And so they posited that by ablating not just the PVC, but also these driver areas, that we could help reduce the VF burden. Oh, going back. This was a little series that we looked at when I was a fellow at Duke, and we happened to have 4 total patients who had recurrent PVC-triggered VF. They'd already had emergent ECMO deployment because of their electrical storm and hemodynamic instability. And we brought them to the lab on ECMO with the primary goal of mapping and ablating their triggering PVC. It just so happened that in these 4 patients on ECMO, they went into spontaneous VF at least twice per patient while in the EP lab with us, and we had the opportunity to watch what happened when they went into VF. I've highlighted their 12 lead EKG for each patient when they went into VF. It's stretched out as we do in the EP lab, but for instance, for patient 1, here's their PVC, and here's their first 3 beats of VF. And for each patient, I've overlaid their second episode of VF, triggered by the same PVC, with their first episode. You can see it most clearly in patient 3, where the lines don't entirely line up. But in all patients, there was high level of correlation in their actual 12 lead EKG morphology with subsequent events of spontaneous VF, essentially supporting, the fantastic work that Dr. Hasigari and his group published, showing that this is a reproducible event in these patients. We saw similar Purkinje triggers to what they found. And in this patient example, who again spontaneously kept going into VF, we found that once we started ablating up that distal Purkinje network, that we were still seeing the PVC and we were still seeing non-sustained polymorphic VT, but even with ablation of the distal Purkinje network, they couldn't go into VF. As we continued to ablate the Purkinje network, we really just kept seeing that PVC without propagating to any arrhythmia, and ultimately ablated that triggering PVC. Now a couple of groups, with this being, I think, the biggest series, have asked the follow-up question, the logical follow-up question. A lot of these patients don't have a PVC to ablate. They might have a PVC-triggered VF, but then when we run a Holter monitor on them, they very rarely have PVCs. And so is it possible that we can do just substrate modification for VF, that we can find those distal Purkinje regions and just ablate those distal Purkinje regions in, like the example I showed before, and actually get these patients a meaningful outcome? And in this particular series, some patients were idiopathic, some patients had cardiomyopathy. They were able to get 16 out of 18 patients with no recurrence in 2 years of follow-up. So I think a really promising and needs more study. So in conclusion, I'd say that if a patient is having many episodes of PVC-triggered VF with otherwise being a stable patient, then substrate modification of the Purkinje network, in addition to PVC ablation, if it's mappable, can be considered for these patients. And this is definitely something that's done at specialized centers in the current era. So in conclusion, first of all, VT ablation has been well proven to reduce recurrent VT and ICD shocks in patients with scar-mediated VT, particularly ischemic patients and those who are refractory or unable to take amiodarone. Second, that VT recurrence after ablation is one of the most consistent predictors of other adverse outcomes like heart failure and mortality across many different subgroups. Third, our patients who have VT, particularly electrical storm and advanced heart failure, require really individualized multidisciplinary care. Comprehensive pre-procedure evaluation as well as intra-procedure management, I think, are really important to helping us get the best long-term outcomes for these patients getting catheter ablation for VT. As I highlight, I think there are some new and emerging technologies that are that make me hopeful that we'll be able to further improve both VT ablation efficacy as well as reduce some of the hemodynamic adverse consequences of putting them through this procedure. And then lastly, in very, very selected candidates, that there may be a role for Purkinje ablation in patients with drug refractory idiopathic or scar-mediated ventricular fibrillation. I want to give a special thanks to my colleagues up on the screen, Dr. Bogan, Dr. Lang, Dr. Ganem, and Dr. Deshmukh, all of whom have been ablating VT here long before I arrived here, and all of whom specifically contributed ideas for the right content to share with this audience. So thank you, guys.
Thank you so much, Dr. Arps. That was absolutely wonderful. And it's so fascinating to delve into the world of VT because I think as a general cardiologist, we see a lot of this and it's like a bucket of VT and I'll say, oh, is it monomorphic? Let me try to see what, no, I'm setting up to EP. But seeing how just like intricate and complex this whole thing is and how far we've come has been absolutely amazing. So thank you. Any questions from the audience? Dr. Pinsky.
That was just stunning, perfect, wonderful, and approachable. Approaching the veins, the perforating vein seems like a technical tour de force. How do you do it? And do you ever have to do something like give them a bunch of volume beforehand so then the channel opens up so you can poke at it?
Yeah, great question. I think this is actually one area in which we really benefit from the variety of procedures that we do. A lot of the concepts relevant to implanting coronary sinus leads for cardiac resynchronization therapy end up being really relevant in those procedures. It's a similar approach in which we're accessing the coronary sinus either with a catheter, which we do for a lot of procedures, or with a wire as we do for CRT implants, and then using a series of wires and microcatheters to get where we're trying to go, just like we do in CRT implants. Just like in every procedure, every patient's anatomy is different. Sometimes it's more technically challenging than others. But the biggest limiter is usually just the size of the veins and the angle of approaching the veins. Honestly, no, it's not something I've thought of. It's not something that we do. The coronary sinus, it's incredibly thin, which you really appreciate the first time you do a heart dissection, but it's actually, compared to the size of a wire or a catheter, fairly large.
Great talk. And I have a question that's kind of tangential, but an ignorant non-electrophysiologist question. You mentioned something that had never occurred to me. The potential danger of the amount of time you put someone in VT or leave them in VT during the procedure. It seems like a bad thing. Are there data that show that's the case, and how much does that factor into your procedure planning?
Oh, that's a great question. I am not aware of any specific trials or studies, but I wouldn't be surprised if someone's put that out, if someone's put out a retrospective series showing that. I can say anecdotally speaking, it's generally accepted as fact in the EP community that the longer a patient spends in VT, the more we worry about them having either intraprocedural or post-procedural decompensation. It's absolutely a factor in pre-procedure planning for our patients who are more tenuous. Using that MRI and CT are actually really helpful because it helps us know whether that scar is something that we'll be able to really easily identify and mapping and use for that more substrate-based ablation. If I have a patient with a mid-myocardial scar, which we often can't specifically map in the EP lab, and really rapid, non-tolerated VT, tenuous hemodynamics, and be a lot more nervous to take them to the lab and counsel the patient differently in that setting than if they have a big ischemic scar. And I say, well, you know, even if we can't keep them in VT, there's a really high likelihood I'll be able to find abnormal signals in that scar and do something with it. When we put the patient in VT in the EP lab, we're constantly watching, every metric we can of their stability, their blood pressure being the most, acute response we have, but then also getting serial blood gases, lactate assessments, looking at urinary output. And we do use that to make the decision about whether we feel comfortable at any phase putting them into VT again, either for mapping or to test inducibility at the end of the case. Dr. Eagle.
Kelly, I really enjoyed your talk. It was really straightforward. To what degree does the device itself and somebody who has an ICD allow you to find the areas that are causing VT? Does it have the capability of informing you if VT is recurrent, or do you still have to do the mapping?
Oh yeah, great question. So we can't determine from the device itself where the VT is coming from, but we can use the tracings from the device to corroborate that a VT circuit or potential circuit that we've found is their clinical VT, that it's the same VT that actually caused them to get shocked in the outpatient setting. When we're inducing VT, or if a patient has spontaneous VT, or if we're pacing to try to match the VT exit sites during a procedure, then we run recordings from the device, which is picking up signals from the same electrograms that they store after a VT episode. And we actually look to see that they match up, because if we induce the same VT in the lab, it should look identical on the device to their first event. So that's something that we employ almost every case.
I have one question. What are generally the drivers of VT recurrence after you do an ablation? Is it like unsuccessful ablation in the first case, or incomplete ablation, or is it driven by the procedure itself creating more scar areas or ischemia?
Yeah, great question. There's definitely data that shows that either a failed initial procedure, meaning we didn't ablate the clinical VT, we were still able to induce it, that's the highest predictor of VT recurrence. And then incomplete ablation, meaning we may have ablated what was their clinical VT, but they were still inducible for other VT morphologies or circuits at the end of the case. That's also a predictor of recurrence. So those are definitely the strongest. But then overall patient factors such as non-ischemic cardiomyopathy and advanced degree of cardiomyopathy tend to be patients who are at higher risk of recurrence. And then those sarcoidosis patients, incredibly high risk, and part of that probably is because of the evolving and patchy nature of their disease.
We have a question in the Zoom. Genetic testing has become more routine, and we are discovering more patients with genetic cardiomyopathies. Are there any studies that evaluated outcomes in genetic and arrhythmogenic cardiomyopathies?
Yes, absolutely. Genetic inflammatory infiltrative cardiomyopathies, all of those are a whole topic in themselves. And so I chose not to include it today. But there's studies in, almost every fairly common genetic cardiomyopathy showing common VT sites and outcomes and patient-specific things with that. Mike Gannam, who now has walked out of the room, recently led a multi-center series looking at desmoplakin cardiomyopathy specifically. And so, yeah, there's a lot of those.
Okay, well, if there are no other questions, thank you again, Dr. Arps, for that fantastic talk.
Thank you all.